Malaria can cause a wide range of respiratory manifestations, from mild symptoms like cough and tachypnea to severe life-threatening complications such as ARDS and pulmonary edema. Respiratory involvement is a significant cause of morbidity and mortality, especially in case of severe falciparum malaria. Let us see respiratory complication and the manifestation of malaria. Respiratory manifestation can occur both in mild and in severe malaria. In mild or uncomplicated malaria, a dry cough is a common symptom, occurring in 20 to 50% of malaria patients. Tachypnea or rapid breathing, which is an increased respiratory rate, can be caused by fever, anemia, and underlying lung involvement. In addition, a small airway obstruction can be there. Lung function test can show evidence of small airway obstruction and reduced capacity for gas diffusion. This suggests subclinical inflammatory changes in the lungs, even in uncomplicated cases. The other is in severe malaria. In severe malaria, there are a lot of respiratory complications. The first is acute respiratory distress syndrome, or ARDS. ARDS is the most severe respiratory complication of malaria, primarily affecting adults and pregnant women, and in rarer cases, young children. It's characterized by severe inflammation, fluid buildup in the lungs, or pulmonary edema, and widespread damage to the tiny air space or alveolus. The mortality rate for malaria-associated ARDS can be very high. The other is pulmonary edema, which is buildup of protein-rich fluid in the lungs due to increased vascular permeability. It is a major component of ARDS and can lead to severe hypoxemia. The other is metabolic acidosis. Severe metabolic acidosis can lead to a compensatory increase in the depth and rate of breathing. In children, deep acidotic breathing is a specific sign of respiratory distress associated with a poorer outcome. The other cause of respiratory distress in a child with malaria may be pneumonia and a co-infection. The symptoms of severe malaria can overlap with those of pneumonia. In malaria endemic regions, co-infection with bacteria is a possibility, and the clinician should have a low threshold for starting broad-spectrum antibiotics when severe respiratory symptoms are present. On physical examination, wheezing and the crackles on respiratory crepitation may be observed in patients with significant lung involvement. The lung damage in severe malaria is caused by a combination of parasite-related and host immune factors. From this, inflammatory response is the first. The breakdown of infected red blood cells release toxins that trigger massive pro-inflammatory cytokine response. This flood of inflammatory cells and the mediators damage the alveolar capillary membrane, causing it to become more permeable. The other is parasite sequestration, especially P. falciparum. In P. falciparum infection, infected red blood cell can stick to the walls of small blood vessels in the lungs. This sequestration can contribute to macrovascular obstruction and inflammation. The other is immune cell activation. The inflammatory response leads to the accumulation of macrophage and monocytes in the lung. In patients with pulmonary edema, these macrophages tend to polarize toward a pro-inflammatory phenotype, which is directly linked to lung damage. In some cases, ARDS can develop or worsen even after anti-malaria treatment has started and the parasite levels have fallen. This suggests a continued inflammatory process that is exacerbated by the initial clearance of parasite. So, given the severity and overlap of respiratory symptoms in malaria, early and accurate diagnosis is critical, particularly in endemic areas. Patients with severe respiratory compromise such as ARDS require ICU management. Mechanical ventilation is often necessary for patients with ARDS to support breathing. However, special care is needed in patients with cerebral malaria, as ventilation strategy must not increase intracranial pressure. To prevent worsening pulmonary edema, fluid resuscitation should be carefully managed. And due to the risk of bacterial co-infection, broad-spectrum antibiotics might be initiated when severe respiratory symptoms are present. Thank you for watching.